You know, my talk has been, or rather panel has been made pretty simple by Dr. Chirag Shah's previous panel on CML, so that kind of takes away quite a lot, and of course probably will be focusing on MPN. So I'll request my esteemed panelists to please come onto the stage. We have got Dr. Sanjay Gandhi, who's a histopathologist here itself at Shalby. We've got Dr. Arshad and Dr. Sridhar, who've come flown in all the way from Chennai, and we've got Dr. Nisarg and Dr. Priyanka again from Ahmedabad. I should say by the time my panel is coming, my panel is extremely, so a little bit of a faux pas which I made was, for the last 3 days I kept on making slides on MDS till I saw my topic yesterday that it was never meant to be on MDS. The topic given to me by the organizers was MPN. So I wrote a quick mail to Dr. Priyanka and everyone, okay, I'll make the slides now. So I actually started making, so the easiest way was the two cases which so both the cases are actually admitted with me in Army Hospital RNR. So the first two cases, one a CML and one MPN case. So I told my JR Medicine to quickly make their case summaries and we'll throw in some questions here and there. So in a way it's a real life situation. Both the patients are actually admitted, and let's see what we can learn, because as we say, although we get taught by a whole galaxy of very esteemed teachers, I think our patients are the biggest teachers. So this lady, she actually came to us from gastro department a couple of months ago. They wanted to do her a splenectomy. She'd been under their follow-up, HCV related. She's the gastroenterologist, again a dear young colleague, Dr. Uday's very close friend called Priyank Dhiman. And he says कि सर हमको स्प्लेनेक्टमी करनी है, वो उसकी हाइपरस्प्लेनिज्म से काउंट्स गिरे जा रहे हैं, just what vaccinations to give pre-splenectomy we are sending to hemat department. So this is the background why this patient actually landed. So you can see HCV related, CLD, big spleen, but now they were bothered about transfusion. Suddenly the transfusion requirement went up, and the patient also agreed that once we remove your spleen, all your problems will be solved. So go to hematology department, they'll give you some vaccines. So as usual, our SRs, they do a very thorough job, not just give. So they took a proper history. They found that she is actually having weight loss of about 5 kgs. Even after PC transfusion, when the HB used to rise up to 10, she did complain of marked fatigue, low grade fever, night sweats, and as you can see, transfusion requirement, platelets between 20 and 30,000, big spleen, normal renal parameters. So my first clinical question will be to Dr. Nisarg, because as a hematologist, when you also get such a case, what's your approach?
Okay, so before advising what vaccination before splenectomy, definitely will investigate this case. First of all, a routine investigation like in CBC, I would like to see what WBC count is. In peripheral smear, I want to see, okay, in WBC, yes, WBC is 21,000. With marked splenomegaly, high WBC count gives me a clue to investigate her further with peripheral smear to look for any shift to left, blast count, to look for RBC morphology, to look for platelet morphology, whether there is any megakaryocytic fragments. Definitely in routine investigation, LDH, LFT, RFT, ferritin level, since she is receiving many blood transfusion. Then obviously before going to splenectomy, I would like to do bone marrow aspiration and biopsy. And as per the report of bone marrow, I would like to do further like MPN panel or mutation.
So I think this is the biggest take-home message, that when for a pancytopenia to a hematologist, if any, irrespective of who sent and what's the indication, we should always look at the marrow, because not doing a marrow is a crime for a hematologist, especially when he's getting a case of pancytopenia. So as was this thing, they very conveniently had forgotten to see the TLC, a high LDH, and a little bit of a leukoerythroblastic blood picture, we found it to be a classical myelofibrotic marrow, grade 2 reticulin fibrosis, clustered MEGS, pan-mylosis, dysbiotic marrow. BCR-ABL was negative, but the JAK2 mutation at exon 14 came positive. So these are the few pictures of the marrow of this patient. So coming to the lone pathologist on our panel, Dr. Sanjay. So now I think I couldn't get the picture of the reticulin, so there was a photograph which showed a grade 2 reticulin fibrosis. Now once you've made a diagnosis, JAK2 mutation positive, BCR-ABL negative, myelofibrosis, clinical picture is there, histopath is there, and now even the molecular study is there. Is it the end, or what do you think is the take on NGS in today's world? Now we are talking of 2025. Your take on NGS in such a scenario?
Now in this case with grade 2 fibrosis, pan-mylosis, it is a easy JAK2 mutation, that this is a case of cellular phase of myelofibrosis. But apart from this JAK2 mutation, there are other co-driver mutation, or we can say passenger mutation, that can say the prognosis in cellular phase of myelofibrosis, such as ASLX1, SRSF2, IDH, IDH2, TAT2. So this will not only tell you also tell the prognosis, because ASLX1 such mutations are associated with little bit poor prognosis. Even RAS mutation will say whether this mutation will patient respond to chemotherapy or not. So definitely I will suggest to do NGS in this case.
I would like to ask my other panelists also, are you also doing NGS in most of your patients of MPN?
Not routinely, sir. So if a patient is really affordable, yes, I would prefer to do the NGS panel. But most of the time, since we have already got a diagnosis with the JAK2 and myelofibrosis, most of our treatment...
Okay, so in which patients would you definitely do?
Sir?
In which patients of myelofibrosis, primary myelofibrosis, would you definitely do an NGS? And supposing money is not the big issue. So if supposing he is being covered by, say, ECHS or a CGHS or anything.
So unusual increased transfusion dependency, sudden progression over a short period of time, say within some 6 months he has got some progressive splenomegaly that has crossed.
So one is clinical basis, absolutely right, so clinical progression. Any other indication besides the clinical progression? Dr. Priyanka?
Triple negative, all the
yeah, I think so. I think the take home message is, for triple negative definitely we should be doing an NGS, rapid progression, and the answer is that although these are the standard definitions of myelofibrosis, major criteria, all three need to be fulfilled. So if the JAK2 CALR or MPL mutation or the presence of any clonal marker, but if you are not having these markers, any of the three driver mutations, then to establish you cannot diagnose a patient with a myelofibrosis unless we have a marker of clonality, because all three major criteria need to be satisfied and one minor criteria. So the diagnosis of either a pre-fibrotic MMA or an overt primary myelofibrosis requires all three major criteria and at least one minor criteria in 2 consecutive determinations. So in our patient, we couldn't do a karyotype because it was a dry type, but when we sent the NGS, it was an ASXL1 positive, and that's what made this patient into a high molecular risk. The repertoire of HMR keeps on increasing, so that these were the original 2, 3, 4 molecular risks which were now on NGS were found to be associated with higher. Now they have added a couple of more markers to it. So JAK, MPL and CALR, as we say, they are the somatic mutations, and you can see on all the MPNs, whether PV, ET or PMF, what is their frequencies at which they are found, and these are these cloner other driver mutations right from TET2 to TP53 down, and their prognostication. So if you see, HMR category is getting increased, in that HMR is high molecular risk, where it's going to make changes in our treatment decisions, because if we have got a young patient, he's got a high molecular risk, the way we'll approach this patient's treatment will differ from say somebody who's not having a high molecular risk of progression or a risk of transformation to AML. So that's the importance of doing an NGS wherever it is indicated, and as the cost is coming down more and more, I think all of us as hematologists need to be aware that it's a very important tool in our clinical decision making. Now once we have made our clinical, histopathological and molecular diagnosis, I think that before you decide treatment, Dr. Priyanka, how do you in your clinic risk stratify your myelofibrotics?
So sir, in this patient we have molecular report. So molecular enhanced IPSS would be ideal. We do not have karyotyping report because it was a dry tap. So MIPSS would be the ideal, and it will help us to decide the therapy in this patient. Sir.
So, you know, this is a nostalgic paper for me. If you see right on top, 26 March 2009, this issue of Blood came out. I was finishing my fellowship at CMC Vellore on 31st March of 2009. So just around 5-6 days before I finished, this paper came up, and Dr. Mahaman Chandy that time said, it looks a very interesting. So in our next journal club, okay, Sanjeevan is going, you present this journal club. So I thought just, you know, just when you are about to leave, you are in a different mold altogether. Jate jate bhi ek kaam de diya. So, but that was the first time when in 2009 March we got to know that it's such a IPSS is so important. I mean prognostication. Otherwise, prior to that, myelofibrosis was treated as a uniform disease. This was a paper which objectively proved that if you just combine these 5 very common clinical age, symptoms, hemoglobin, WBC and peripheral blood blast, as simple as that, you can't get more basic than your CBC and your clinical examination. Based on that, you give them a scoring, 1 mark per symptom. So anyone can get 0 to as high as 5, and just divide them into the 3 risk groups and look at the graphs. So they just separate out like anything. So as simple as, you know, doing it in the clinic, that IPSS concept came up in March 2009. And of course, as Dr. Priyanka mentioned, now we have got then the dynamic IPSS came up, then the DIPS plus came up, then the molecular inspired IPSS came up, the MIP70. Now you got a plethora of scoring systems, classification systems, and the idea of all these things is very simple. You need to decide how we will treat our patients. We cannot treat all our myelofibrotics in the same manner. So a simple thing today has become on your mobile. I'll request all our young hematologists to make it a point that a risk scoring will be done at every visit. Make it some periodicity, maybe once in a year, once in a quarter. And it's a simple scoring system. Just type this on your search, pmfscorecalculator.com. It takes probably less than 5 minutes. Now I've seen with practice it is now taking me around 3 to 4 minutes. You just fill in the it's a self-filling paper. Most of the time it is MCQ. You just click yes no answers. There are some 13-14 variables. So they'll be asking, okay, whether this cytogenetics is there. Yes, no, not available. Even not available is an option. So if you just go on to the pmfscorecalculator.com, within 3 to 4 minutes at the end of it, it will give you all the scores. So the DIP score is this much, the MIP70 is this much, the MySec score is so much. This is the probability of survival. This is the probability of progression to AML. So all the things will come at the bottom. So you can document it in the patient's chart, and it's made our lives so easy. And it makes, sometimes I have taught my, the aware and the alert and the educated patient that you can also do your, especially in MDS and MPF. Now I am telling my patients, please do your own scoring. So the patient comes on his mobile, ki this is my score today. So he himself is aware of whether I am a low risk or I am a high risk, and it's easy to counsel such a patient. So Dr. Arshad, now you know the risk score is pretty high. So for this lady, it was a high risk. So how do you plan treatment in this patient?
Sir, regarding this lady, if we calculate as per DIPS or IPSS scoring, she will be coming at intermediate 2, I think, with the
intermediate 2.
yeah, anemia as well as
she's got all.
She has blast and
got
constitutional symptoms. So three scores she has got. And if we come to the MIP scoring system, she will be adding on with the AXXL1. So either intermediate 2 or high risk.
So her median survival as per the score calculator was 1.6 years.
Yes, sir.
So at a 32-year-old lady, her survival would be 1.6 years. That's what that score also tells you what's her median survival.
And she has obviously got a massive splenomegaly with thrombocytopenia also. So if she is fit enough to go for a transplant, we have to plan accordingly. We have to initially put her on Jakavi, try to reduce her spleen size to a certain level, assess her ferritin status, definitely reduce her iron overload. Then maybe if she has a suitable donor, we'll plan transplant.
So very well said. Put her on Jakavi. Now the first thing Jakavi people say, don't give it to people less than 50,000 platelet counts. Here our platelet counts are 20,000. What do you do?
So in this case, we can slightly start at a lower dose, maybe 5 mg once daily, something like that. Or I think recent JAK2 inhibitors are available.
So that's the third take home message. So this is what the treatment algorithm current guidelines say. If you got a myelofibrosis, first check whether she is SCT eligible or not. The first algorithm starts here based on her age, her PS, her comorbidity index, life expectancy. So any life expectancy less than 5 years and her good PS is there, we should first say that she or he is a transplant eligible. If transplant eligibility is there, donor is availability, and we know that there is a good survival, straight away put her on a short dose of what Dr. Arshad just mentioned. Any of the, now of course probably in India we don't get fedratinib or paxlotinib, but Rux is available. Whatever dose is, MTD is the keyword, what you see. MTD is maximum tolerated dose. So don't go by what the guidelines say that 15 milligrams twice a day. If she can tolerate 5 mg, give her 5 mg, the benefit of 5 mg. Don't go for the 15 mg and straight away take up for transplant. Whatever dose she is able to tolerate, so that you are able to reduce the spleen size, because if you take up with a big spleen, our transplant outcomes would be poor. Whereas in other ways, if SCG eligibility is not, I mean donor is not really available and there are other issues, then we go on a need-based strategy, because first we have to address the symptomatic splenomegaly. And in that splenomegaly, again you divide it into a low risk or a non-low risk. Then for a low risk you can still try with the hydroxyurea, PEG interferon. Let me tell you, PEG interferon is not a dead drug, it's a very active drug. So it's a beautiful drug, and we should not as hematologists lose sight of this drug, because you know it's kind of gone out of flavor. And if it's a non-low risk, then depending whether the platelet counts are less than or more than 50,000, we will be giving the JAK-I inhibitors. Still, as per guidelines, it's Rux and fedratinib is only for people above 50,000 platelet counts, and pacritinib for people with less than 50,000 counts. Then of course we manage her anemia with ESAs and other things, and symptomatic management is equally important, not just the transplant. So what we did was, we started her on a low dose of JAK2. She tolerated 5 mg. Now we've gradually built up to 10 mg BD, and spleen size is going down gradually. Decitabine had to be added because she had got circulating blast 12% to 15% and other ESAs. Luckily she's got a full matched brother, 28 years, and so she's a transplant candidate, and we are working up, although it's still a long way out, but probably by the end of the year we expect to transplant this patient. Now Dr. Sridhar, if you were to be planning this transplant, when would you time it, and what would be choice of conditioning?
So again, timing, as Dr. Ashad was mentioning, so again we have to reduce the spleen size as much as possible and reduce the ferritin values. So that will be because now the patient is having full match, and probably this is slightly coming under control with Rux. So probably this may be the right time to transplant, and because she is also having a full match sibling. And the conditioning, again, despite like even the transplant era, the myelofibrosis transplant is slightly trickier. So basically, again, it's, there is a call between RIC versus myeloablative. So again, recent data with even EBMT data says that myeloablative is slightly better compared to the FRIC regimen.
Yeah. So I think that's what you rightly, because eventually I think Dr. Satyendra had also pointed out, not in the context of MPN but in the previous, transplant is a one-shot treatment, and as hematologists we should never lose sight of the fact that this is the curative treatment, and we have to make our patient fit. Now supposing if this gentleman was an elderly gentleman, probably, but in a 32-year-old person I would not like to compromise on the conditioning, because ideally if it is MAC conditioning, because we have to get rid of the clonal stem cells here. So probably make her fit enough to undergo the transplant, and as much as is feasible, because it's only 25% of our patients who will actually get a matched sibling donor available. Ideal situation, go ahead, do the transplant, and try and achieve a cure.
So boss, recently I was in touch with Dr. Bori Anderson. So I asked him a very categorical question, and I am sharing it. So anybody who will transplant, Dr. Bori Anderson, professor, is from MD Anderson. So he said, even if you are using a RIC transplant, but if your primary is a clonal disorder, please include drugs which are gonna take care of the clonal stem cells like busulfan. So MD Anderson has got a lot of work onto the bu. So he said that even if you are going for bu-flu, maybe just bu-mel, but include bu if you want to target the leukemic stem cells or the stem cells which have led to evolution of a clone. So any conditioning might be okay depending on the patient, but choose the agents based on this. So bu and then bu with level. They are very sure about it. We less of centers have the bu level, but as a hematologist we should all have now bu levels. So that's what.
Yeah, I think most of I'm not aware about Ahmedabad whether I think bu levels would be available here at all, because in Delhi most of us are doing bu levels for our transplants. Okay, sir.
As a sequelae, we know in RIC that relapses are higher. That's because we are not wiping out the clonality of cells. So you must target it to the, that's why you have reduced toxicity conditioning today. In between a RIC and a MAC. But you want to get rid of that, that villain.
So, the take home messages from our first case, the topic given by Dr. Aishwarya is what is new. So if I were to summarize in just 2 lines, what is new? One is role of NGS, the role of risk classification as per the standard guidelines, and of course options are available. Give the patient the best available. Primary myelofibrosis or any of the MPNs is a very highly treatable condition, and not one of those conditions in which we have got limited options still as they were about say 10-15 years ago. Now second case, of course, I'll just rush through. We've already discussed a lot and we'll come straight to the last slide where what is new in CML I'd like to add. So this is ex-army volleyball team player and now retired, leading a nice life in retired life in Kerala, had acute pain and he went to Bengaluru. We have got an armed forces hospital there where they found marked pallor and some tenderness, some spleen. They found anemia with a platelet of 34,000 and a WBC of 1,13,000, 60% peripheral blast, TLS in form of high uric acid and LDH, little bit of renal dysfunction, normal liver, and again when they did a marrow, they found a CD10, 19, 34 positive lymphoid blasts. All metaphases showed the translocation 922, peripheral blood by a fish which had been sent previously, again showed 93, 922 and 100%, and 210 transcript came positive on peripheral blood. So Dr. Sanjay, this is a very common question. So this is CML in lymphoid BC or a pH positive ALL?
At this stage, it's very difficult to say whether it is a CML crisis or pH positive ALL, but still 60% blast in peripheral smear and 100% cells showing positivity, 100% in interface cells in fish. So it is more likely to be pH CML in blast crisis. But
So
still, subsequently, once the blasts are reduced, I will again repeat the same, and if the cells are disproportionately increased, then I can confirm that this is a CML.
Correct.
With
So that's the important message. Yes, although it's only nomenclature wise because TKI and therapy more or less, but yes, we should be clear what we are treating. So we were treating lymphoid BC CML. And Dr. Sridhar, how would you start therapy in such a case?
So again, it's now it's a lymphoid crisis, sir. So it's because lymphoid crisis. So we'll start with like typical to adult ALL protocol with TKI. So this patient will start on most likely the GML protocol with some dose adjustment with dasatinib, preferably 140 mg.
Great. So I think this is a pretty straightforward. We also started GMOL, dasatinib, day 33, marrow was in remission, MRD by flow negative. BCR-ABL also started coming down. So we continued another GMOL for another 3 months, and end of consolidation MRD was again negative by flow. So there was a little bit of a domestic issue at home. She had a 12, so there are just 3 siblings and all 3 of them were actually identical. So again a rare phenomena that he's got a 55-year-old sister and a 53-year-old brother, and all 3 of them are actually identical. The only issue at the family was that the brother is already in Gulf, so he is not present in India, and the sister was moving out for about 6 months to Gulf. So there was a crisis that if the transplant had to be done, it had to be done now. So otherwise the sister, the donor won't be available for the next 6 to 8 months. So both his sons were haplomatched. So we quickly this patient was transferred from that Bangalore hospital to us for transplant. So they said that we have already achieved MRD negativity. We are giving you on a platter, just because in our Bangalore hospital they don't do allo transplants as of now. So they were transferred to Delhi for just doing the allo transplant. So Dr. Arshad, if you were in this situation, what would you do? MRD negative 2 times, end of consolidation, end of induction.
Sir, obviously this is a CML in blast crisis. I would have better gone for an IRMA mutation analysis at the beginning itself, just to know whether it's all working up or not. Obviously RQPCR has come down, MRD is negative. Still better option in this case would be to go for a transplant. We all know the overall survival even with chemo will be very less, like it's around 1 year only, median OS. So in such cases I would prefer to go for a transplant in this case.
Yeah, I think so. That is what we did. We actually gave him a MAC conditioning allo SCT from sister and grafted. So everything was going very smooth. Discharged by day 17, chimerism day 30, 98%, anything which keeps the transplanter happy. Only thing was, Dr. Satyendra had also pointed out no GVHD till day 50. So that is not a good sign actually for a transplanter. No, although they were giving him cyclosporine as low doses as 75 milligrams twice a day, and still no GVHD. When he developed hip pain on day 57, we knew we are in trouble. MRI showed hyperintense lesion in the right acetabulum. Biopsy showed sheets of blast. So he had actually an extramedullary relapse. Within 2 months of transplant, BCR-ABL this time was 13%, and now when we did a TKD, we found a T315I mutation. So we stopped all IST, gave palliative RT, started PONA. With that he developed severe thrombocytopenia. So as I think Dr. Nisarg will also say, so what we did wrong?
I think as patient presented initially in blast crisis, we could have done tyrosine kinase domain mutation at the beginning, so that we can we could have planned TKI accordingly. Maybe this thing may go wrong. Otherwise, I think.
Yeah, I think. So then, what would you do now? Now
Yeah,
that you have gone wrong.
Yeah. Now I will continue with as patient was started on 30 mg ponatinib. We'll continue with 30 mg and we'll keep monitoring monitor his BCR ABL, and if he is tolerating 30 mg, I will try to increase the dose to 45 mg and keep monitoring monitor his BCR
So we have
ABL
asked
and
for asciminib also for this patient.
yes. Say if on ponatinib
Because
patient is not
dropped platelets to 30,000. So we have asked for asciminib. Supposing with asciminib we get him into a CMR, then
The dose is much higher when you use asciminib here.
then I think there's another brother who's sitting there. We should do a transplant.
So in such cases, Sanjeevan, actually you need a good GVL.
Exactly.
You know, actually when you have a BC in such cases, my experience has been that if you don't have a good GVL, and that too older donor, more than 50, 55, they are not the best quality donors. So you have even later relapses in these cases. So I may have opted for a
Haplo son.
haplo with the child son, you know, as a donor, and gone ahead and look for a better GVL. And no, in retrospect.
In retrospect, we are all wise. So I think Dr. Satyendra very rightly pointed out earlier, you know, transplant is a art more than a science. And as a transplanter, sometimes we are tempted by no GVHD, easy to do, 12 by 12 sister, you know, so many things which are favoring us. Somebody is treated outside, only sent to you for a transplant. But comprehensively looking at a patient, he is relapsed within 2 months of a transplant. So where have we? We are actually back to square one. So sometimes we have to take the hard decisions. Maybe
so the art has to meet the science.
Yes, so art has to meet the science.
There has to be an
and
interface.
Probably we should have sent the patient back to Bangalore. First get your BCR ABL negative, whether by PONA or by this thing, because you've got a T315I mutation sitting. And these are the indications, the ELN 2020 guidelines, which say at diagnosis only in AP and BC is it indicated, nowhere else. And this patient was a BC. So it should have been done upfront in Bangalore. It wasn't done. That's a different issue. But yeah, this is, you know, this is how we learn. So place of asciminib, Dr. Priyanka, one quick word.
So we have already had 2 good sessions about asciminib.
Yeah.
We have T315 mutation beyond 2 line, and now we have in first line also.
Yeah,
So one question I wanted to ask is accelerated phase and blast phase. We don't have approval for asciminib as of, like the patient before we discussed presented with a blast phase upfront.
No, I'm saying indication for doing TKD mutation.
Okay.
That
No,
slide was for TKD.
Okay.
When should you do TKD mutation upfront? At diagnosis only in AP and BC.
No, sir.
No, sir.
You said that you are thinking about asciminib also in this patient.
No. Now because of intolerance. Now
Intolerance, okay.
He is already relapsed. He's got an extramedullary relapse. Peripheral blood has just got some 12-13% blast, but he's got an extramedullary relapse which has improved. Now we have to get the disease under control, and once we get the disease under control, probably this time now we'll take the son as the donor and transplant. So, you know, I think these are the things which had already been highlighted by Dr. Chirag's panel. The new things, what is happening in the CML space. One is the intolerance and the compliance issue. So what I have started now, TFR is something which all of us as hematologists should be discussing with our patients at diagnosis. So what I have seen is in the last 5-7 years is, if you tell a patient that you've got a disease in which you have to take a lifelong treatment, his motivation to compliance is zero. You say, you make it conditional, that you can be cured of your disease if your compliance is more than 90-95%. Give him that leeway ki mahine mein ek din he can miss out, but not more than one. So Dr. Chirag has said 3 days or 4 days in a month. I give them a leeway of only 1 dose missing in a month. and compliance is good, you are an eligible person for TFR. Optimal dosing, again as mentioned, whatever keeps your BCR-ABL 0 is the dose, not 400 or 800 or 150. And of course switching, Dr. Velu had mentioned, sometimes just switching between nilotinib to dasatinib to bosutinib may not be the right. If one second generation TKI is not working, 90% of the time the other also won't work. So we may have to bite the bullet. We have to come into the third generation TKI, which is ponatinib or asciminib, or the third ones whose name I don't remember. TFR counseling, as I said, upfront, it is not an afterthought. All newly diagnosed patient, you have to say you are a candidate for TFR after 5-7 years, depending on how, and of course pregnancy in CML is a topic in itself. So thank you my panelists.